Good evening, everyone. Shubha Sanjay Ellarigu. To begin the web talk, let us first begin with I am a prayer. May everybody be happy. May everybody be healthy.
happy.
May everybody be healthy.
May everybody be
Everybody
healthy.
be healthy.
May everybody be free from pain.
May everybody be free from pain.
May everybody be free from sorrow.
May everybody be free
Everybody
from
be free
sorrow.
from sorrow.
May we be the healing cure
May we be the healing
May
cure.
be healing cure.
beyond every greed and lure.
Every
Yeah,
great and
very great. Good.
Okay. Thank you, sir. I welcome our President, sir, Secretary, sir, and all the IMA KSB members and the delegates who have joined for today's talk. Now, we from Academic Committee are conducting every month webinar by one of our faculty. So today's webinar is by Dr. Ashwin Kulkarni, who is a faculty of Ramaya Medical College. He is an associate professor in a department of medicine. So today he will brief us about the diabetic in general. So he'll be telling us about the diabetic and the related consequences, things, treatment, everything about the diabetes. So to chair this session, Dr. Jawaz sir, Syed Jawaz sir will chair the session. And now I request Dr. Harisha Dalintapetru sir to give a brief introduction about Jawaz sir.
Sir, how about President's remarks?
Yes.
Yeah.
Hello.
ಹೇಳಿ ಮೇಡಮ್.
Sir.
Hello, can you hear
Just
me?
2 words for us.
No. Okay, good evening to everyone. Today I got a very good topic like diabetic mellitus, conducted through IMA KSB and academic subcommittee. Dr. Karunakaran, Secretary of KSB, Treasurer Vijay Sarathi, and Chairman of this academic subcommittee, Sanjana Patil Tallur Madam, and also our well-known resource person Harish Dalintapetru sir, and all the President-elect Srinivas, and all the esteemed members of this IMA KSB. Today is the very common problem we are facing all over the world, especially in India also. Diabetes is more than 40 to 50%. I don't know, it may have increased also. And we have got a very good renowned speaker like Ashwin Kulkarni, Assistant Professor of Ramaya Medical College. He happened to be from Bijapur, Gulbarga, and Chairperson Dr. Syed Jawar, and he's a director and also diabetic and research education founder. We are fortunate to have you, sir. Welcome you all.
Thank you.
I don't want to take much time. I hand over the mic to Harish Dalintapetru sir for the further.
Thank you, sir. Thank you, President, sir. Thank you very much.
Ashwin,
Okay.
the topic is very broad.
Yes, ma'am.
Such a broad that I think we would have had gone little depth or the specific topic in it. The diabetes being a general topic, but however, next time I think we are going to specify what exactly one has to speak about diabetes. However, in general, according to the International Diabetes Federation, today globally we have about nearly 537 million diabetic patients today in the world, and by 2040 it is going to rise up to 642 million. India alone has about 80 million diabetic patients today, and by 2040 it is going to be 134.2 million, and double the 80 million today, double the number of patients we have are standing in the pre-diabetes queue. And India being the capital city of the diabetes in the world, every 11th patient in the world is a diabetic. Of course, just to know, Kerala and Tamil Nadu are the highest number of diabetic patients, and with Rajasthan and Haryana, there are lower number of diabetic patients. In diabetes, we have about more than 90 to 95% of the patients are type 2 diabetes, and we have about 2 to 5% of type 1 diabetes. 17% of all total number of diabetic patients in the world are Indians. So the risk factors of the diabetic patient Dr. Kulkarni is going to discuss about pre-diabetes, overweight, and type 2 diabetes above 45 years of age, and family history, sedentary lifestyle, and converting type 2 from GDM, gestational diabetes, are all very important, and is going to speak about all the management of diabetes. Diabetes is not any bacterial or a fungal or a viral disease to be treated. It is a lifestyle disorder, needs a lot of self-management and lifestyle modification. Over to Dr. Ashwin Kulkarni to go ahead with the subject
Thank you, sir.
matter.
Thank you very much.
Interruption. I would like
Chairperson.
Harisha sir to introduce Jawaz
Yeah.
sir, because
Yeah.
he's well known in diabetics. So let sir introduce first.
Yeah, sir, thank you very much for your opening remarks.
Ji,
Dr. Syed Javed sir,
Ji, sir.
Director, Diabetic Chemistry, Research and Education Foundation from Bangalore. Sir, I would like to introduce you on behalf of IMA KSB Academic Subcommittee. Dr. Syed sir is a Chief Consultant Diabetologist, Diascope Polyclinic and Laboratory at Bangalore. He is currently Chief Consultant Diabetologist at Diascope Polyclinic and Laboratory, and he is ex-medical superintendent and trustee at Bangalore Diabetes Hospital, and he got his MBBS and MD from Bangalore Medical College. He got his post-graduation PGCDM from Indore, and also completed a postgraduate course as a fellow in diabetes care at University of Newcastle, New South Wales, Australia. Sir is passionate about diabetic treatment, care, research and education. He is the founder and director of Diabetes Chemistry, Research and Education Foundation, Bangalore. He is a chief patron of Karnataka Diabetic Foundation. This is an organization aimed to spread diabetic health awareness. His main fields of interest are diabetes, obesity, and metabolic medicine. And on these topics, he has presented multiple articles and scientific presentations. Dr. Jawaz has conducted various national diabetic conferences in India and has produced academic papers both in national and international level. He is the main principal investigator for largest clinical trials in Asia countries for PERSIST study, and he has produced this study at American Diabetic Association, European Association for the Study of Diabetes, and International Diabetes Federation. He is a member of Research Society for the Study of Diabetes in India. He is the founder of and honorary secretary for the same association, RSSB. I hereby present Dr. Sir, and he is also active member of IMA. He is the treasurer of IMA. I don't know which branch, sir.
Ex-treasurer and ex-vice president at Bangalore branch.
Bangalore branch, yes, Bangalore branch. Thank you very much, sir. Welcome to you.
Thank you for your kind.
Thank you.
Ashwin.
Kulkarni, you can go ahead, Ashwin.
Ashwin.
Yes, sir. I'm going to share the screen. So good evening, everyone. Thanks for the warm introduction. And I thank our chairperson today, Dr. Syed sir, for giving such a good introduction, and it has set the stage for the further discussion. As sir mentioned, that diabetes is one of the very huge topics, and it's a very difficult task for me to condense everything and talk about half an hour or so. But today's mainly I'll be dealing with about the general clinical features and broad management of diabetes, with an objective of creating an awareness among the general practitioners and the new doctors about the current latest medications and trends involved in the diabetes. As sir mentioned, diabetes is one of the lifestyle disease. It is not any bacterial or viral disease, as sir mentioned. It's a metabolic disease characterized by basically high blood sugars. It's a metabolic disorder of multiple etiology characterized by disturbance of carbohydrate, fat, and protein metabolism. It basically results from defects in insulin secretion and insulin action, and sometimes both. So going directly to the types of diabetes, since the availability of time. So broadly, diabetes have been classified into various types. For clinical varieties, there is type 1 diabetes mellitus, type 2 diabetes mellitus, gestational diabetes, and other types which are rare, but still as practitioner, we should be aware of are the term called as LADA, MODY, that is maturity onset diabetes, and secondary diabetes mellitus, which I'll be telling about a slide each. So type 1 diabetes mellitus, as all of us know, it is insulin-dependent diabetes mellitus or juvenile onset diabetes mellitus. Most of the time it is autoimmune in condition, but there are some conditions, some types around 10 to 20% where it can be idiopathic without any autoimmunity also. It usually affects children and young adult, although can occur at any age. Around 5 to 10% of all the cases of diabetes currently can be attributed to the type 1 diabetes mellitus. As I mentioned, the risk factor for type 1 diabetes is usually autoimmune, and most of the time it is genetic, and rarely it can be idiopathic as well as environmental causes. So now the crux of the situation now is a type 2 diabetes mellitus, which is the need of hour for all of us to have a in-depth knowledge and also formulate various good treatment strategies so that the complications can be limited. So type 2 diabetes mellitus is basically non-insulin dependent, which is routinely called. It accounts for 90 to 95% of all the diabetic cases, albeit also in spite it is mainly told that it is in adults, but steadily increasing in the adolescents age group also. So basically why type 2 diabetes is, it is because of insulin resistance. So one point we should understand, what is insulin resistance mean? It means that insulin is there, rather sometimes insulin is increased in amount, but it is not adequately utilized. So it is at the level of receptor levels, at the level of adipose tissue, at the level of skeletal muscles. So this leads to increase the pancreatic burnout and finally leads to insulin deficiency ultimately. So most of the time it is associated with obesity, family history of diabetes, anyone who has history of GDM, physical inactivity, and sometimes race, like as sir has mentioned about the number of Asians and Indians being increasing in number and are getting affected by diabetes. This slide, the important point which I want to stress here is the insulin resistance is the key word which we have to understand. So unless and until insulin resistance is dealt with properly, the insulin diabetes is not going to get cured or it's not going to be under control. So insulin resistance is basically by the modifiable risk factor, that is obesity. So hence anything which is targeting obesity, that is lifestyle changes, is the main important crux, main important treatment for the management of type 2 diabetes mellitus. Rest, physical inactivity and all we have understood. So of late, what we have seen is from the pandemic of COVID, we are seeing a lot of younger patients coming to a hospital with a lot of non-specific complaints. And when we eventually evaluate them, it turns out that they are having diabetes mellitus. So it is increasingly common, starting from the third decade itself, just to people who are in the 20s, early 20s, 25s, 30s, 35s are having increasing amount of incidence of diabetes mellitus. So as I mentioned here, type 2 diabetes mellitus, high refined carbohydrate intake with low micronutrient sedentary lifestyle and some genetics basically finally, because when we inherit the insulin resistant genes from our parents, so we are more susceptible to develop type 2 diabetes. So insulin levels increase, cells become resistant, glucose and insulin levels are high, pancreas finally decrease the insulin production, so ultimately leading to type 2 diabetes mellitus. So same thing what I mentioned here, slightly in a better manner, like how the obesity, the lifestyle changes and the genetic predisposition together leads to insulin resistance, compensatory beta cell hyperplasia, which can transiently cause normoglycemia, but ultimately leading to beta cell failure and diabetes. GDM, which is coming up in number, and next month we are going to have a special session on GDM also, where it will be dealt with in more detail. Gestational diabetes occurs in pregnancy, more common in obese women and women with family history of diabetes. Treatment to normalize maternal glucose we have to do to reduce the risk of congenital anomalies, fetal macrosomia, and lot of pregnancy related adverse events. After pregnancy, around 5 to 10% of patients still continue to have diabetes, and 20 to 50% of them have chance of developing diabetes. So take home message from this slide for all the practitioners is women who have had history of having large babies or history of having GDM are more and more predisposed to develop diabetes, even though their immediate postpartum sugars might have come back to normal, but they are susceptible to develop type 2 diabetes in future life. So LADA, this is one of the terms which we should be aware of. It is latent autoimmune diabetes. It behaves like autoimmune diabetes, but it is slightly occurs in the older individual. It is also called as 1.5 DM. So in between 1 and 2, type 1, type 2, it is 1.5 diabetes. It is slow onset of diabetes. Oftenly it is mistaken for type 2, but it is autoimmune in nature. For a general awareness, we should be aware that these terms exist, and patients, we can know about these patients. So usually patients are more than 25 years and they masquerade as non-obese type 2 diabetes mellitus. Initial control can be achieved by diet alone, but sometimes in future OADs and insulin might be required. MODI, just a one slide regarding MODI. MODI is our maturity onset of diabetes of young. MODI is a monogenic form of autosomal dominant inheritance. Mutations in various enzymes like glucokinase can lead to MODI. It can occur at any age, but family history may not always be obvious. So basically, these are the genetic genes which HNF1 alpha, HNF4 alpha mutations. Young onset diabetes, usually less than 25 years, strong family history of diabetes. Generally, they are susceptible or sensitive to sulfonylureas. So these are the two rarer forms of diabetes which we should be aware. Secondary diabetes is a term used when the diabetes is because of any other secondary illness. It can be because of other endocrine disorders like acromegaly, Cushing syndrome, pheochromocytoma, even because of chronic pancreatitis. Some drugs, this we should be increasingly aware, especially the practitioners. Atypical antipsychotics, they can predispose people to develop diabetes mellitus. Patients on beta blockers can also, in around 5% of chances, they can develop diabetes. Patients on corticosteroids, as we all aware that long-term steroids therapy can lead to diabetes, and even niacin and HIV drugs like protease inhibitors also can cause secondary diabetes mellitus. So coming to this is one of the important entity, as Javed sir mentioned now, pre-diabetes. So it may have impaired fasting glucose or impaired glucose tolerance. It's a condition where fasting glucose is in between 100 to 125, and IGT, where the impaired glucose tolerance after glucose challenge is in between 140 to 200. It might look like, why are we stressing so much on impaired? But always remember, this is one of the golden period, and this period should not be left. Pre-diabetes has to be identified. Patients have to be warned. They should be counseled regarding potential role of lifestyle changes at this point, because if the patients are left now telling that, okay, this is borderline and I can do away with that, no, it is not like that. These patients definitely develop diabetes in future, and they're equally prone to develop all the complications. So it is one of the ripe periods for doctors like us to counsel the patients at the pre-diabetes stage to have an aggressive lifestyle and dietary modifications. So we can prevent the progression to diabetes with the patient who are having pre-diabetes. We should promote weight loss, increase physical activity for these patients. There are some studies which have told that treatment with metformin at pre-diabetes is good, and many of the time in patients who are obese, who are having strong family history of diabetes and risk factors, doctors do start them on metformin so as to prevent them from developing diabetes. But pre-diabetes is one of the very, very important entity which all the doctors should be aware of. So coming to the clinical features, often the symptoms, this is something which we can feel that where doctor's role comes. Most of the time, patients do not come to the hospital with history of the typical symptoms like polydipsia, polyphagia, and so. Many times symptoms are not there and sometimes absent. Many times when the symptoms come, it is very, very long that patients has already developed diabetes, their HbA1c are very high. But generally patients who come present to the hospitals are with increasing thirst, polyuria, blurring of vision, weight loss. Of late, we are seeing a lot of patients who just come with vague fatigue, vague restlessness, weight loss. Especially in the post-COVID era, we are seeing a lot of patients with vague fatigue, body ache, burning sensation of feet, hands, legs. So all of these things warrant us to check their sugars. Not only sugars, we have to check their HbA1c, which is the which gives us a definite treatment of diabetes. So typical these symptoms are polyuria, polydipsia, polyphagia, weight loss, burning of vision, burning sensation of feet, fatigue, fungal infections, and non-healing wounds on the feet. So these are the various symptoms of diabetes which we should be aware of. And when we examine, we should especially look at these signs. So these are the signs of insulin resistance. It's called as acanthosis nigricans, thickened blackish velvety appearance of nape of the neck, velvety appearance of the dorsal surface of the palms, soles, and various markers of these are called as insulin resistance markers, which we should be specially aware of. Many times patients do complain with these infections of herpes zoster. When they come with dysphagia and we do an endoscopy, we saw fungal infections. This could be the first time where they are getting diagnosed with diabetes. So whenever patient comes with skin infections, fungal infections, viral exanthems like herpes zoster, doctors should be very careful to evaluate sugars in these group of patients. Now, before going to the treatment per se, we should be aware of what are the complications so that we can start screening of these patients at the beginning of the diabetes itself. So there are classifications can be classified as acute complications and chronic complications. Acute complications where patients can present to the hospital with diabetic ketoacidosis. They can have hyperosmolar or non-ketotic state. Sometimes who are on treatment can come with hypoglycemia, and even lactic acidosis can be an acute complications. Chronic complication, which all the doctors should be aware, and especially be aware of the newly diagnosed, and also when they come for the screening of the patients. So microvascular and macrovascular, neuropathy, nephropathy, and retinopathy are basically microvascular complications. They can have burning sensation of feet, peripheral neuropathy, non-healing wounds on the feet. Nephropathy, where they excrete urine proteins in the urine and leading to end-stage renal disease gradually. Retinopathy, where the retina will get affected with microaneurysms, bleeds in the retina, proliferative, non-proliferative retinopathies, and so on. Macrovascular, where the large vessels are involved, coronary artery disease, stroke, peripheral artery disease are the cardinal things. And then diabetic foot, which has components of both microvascular as well as macrovascular, related to neuropathy as well as vasculopathy. Diabetic foot has a major brunt on the health of and wellness of a lot of patients. So my purpose of putting this slide initially is by knowing awareness of these complications, we should screen for all these patients at the diagnosis and also serially screen them during the course of the treatment. So coming to the diagnosis of diabetes mellitus, this is the algorithm of American Diabetic Association. HbA1c, which is the average of the blood sugar, should be done in all the patients at the time of diagnosis. Less than 5.5, 5.7 is normal. 5.7 to 6.5 is the pre-diabetic range where aggressive lifestyle and dietary modification should be suggested. HbA1c of more than 6.5 indicates frank diabetes mellitus. And also fasting blood sugar of more than 126, 2-hour glucose of more than 200. Guidelines have random sugar of more than 200 with the symptoms, but generally we do not start the treatment with random. We should know fasting and 2-hour components regarding which part of the insulin secretion is abnormal or which part of the sugar has to be tackled well. So hence fasting blood sugar, 2-hour ppbs and HbA1c should be done at all the patients at the time of diagnosis and also at the time of follow-up. Coming to the investigations for a newly diagnosed, if a person has got newly diagnosed diabetes, we have to screen for his pre-existing complications. As I mentioned, many patients, when they present with the first diagnosis itself, they are having a lot of complications. So it is our duty to make sure that we address them because our treatment modalities vary with the various, with their comorbidities and also at their various baseline levels. So any patient who is newly diagnosed, we have to do his renal function test, look at his creatinine. Not only creatinine, here I want to stress a point to our general practitioners and also new students or new doctors that creatinine may be normal even till the late stage of diabetic nephropathy. So hence the urinary excretion of albumin should be looked at, especially microalbumin should be looked at in the initial stages so that it gives us a startled response so that we have to be more aggressive in their diabetic control. So all the patients should be done a urinary routine screen and also look at the microalbuminuria. At the initial start of treatment, we should do their thyroid profile, because many times untreated hypothyroidism can also lead to insulin resistance, and correction of thyroid can help us in better management of diabetes. At this stage, we should also do fasting lipid profile and hypertension, as we all know that all of these have similar risk factors, especially dyslipidemia, hypercholesterolemia, and diabetes. In all constellation called as metabolic syndrome, it is called as syndrome X, have all the similar risk factors. So at the start of diagnosis, we should screen for all of these things so that we can give a holistic treatment, a holistic approach to our patients. Also an ECG to look for pre-existing coronary artery disease or any other cardiac status we should be aware, as many of the drugs do have cardiac issues. So if the patients have cardiac issues, then our method of treatment will be different. And also a fundus examination to screen for the patients for retinopathy has to be done at the start of diagnosis. Also annual checkups once a patient is diagnosed, also measurement of serum creatinine levels serially, microalbumin levels, ECG, looking for ECG, retinopathy, and especially things examination for neuropathy. It is not that when the patient develops ulcer, we need to get aware. Even when the patient has come, we can inquire regarding their symptoms of neuropathy, like burning sensation of feet, numbness, not able to sense hot water, cold water, etc. And simple tests, a simple ankle jerk can help us understand neuropathy. Looking for the vibration sense, it's the first sense to go in diabetic neuropathy can be looked for. Microfilaments are available everywhere. So looking for the microfilament test, looking for the neuropathy can help us in a comprehensive management and helping our patients of diabetes. Now entering to the management. So I'll try to be very brief so as to know how it is to be approached. So there are three main components all of us have to follow: diet and exercise, oral medications, and insulin. Most of the time what happens is doctors, we tend to directly jump into the medications, but we should not forget that diet and exercise are the cornerstone of the treatment of diabetes. So we should spend a good amount of time explaining to the patients regarding what to eat, what not to eat, how much to exercise, what to exercise. And also exercise should be given based on their tolerance, based on their age. So we have to customize a kind of thing like what exercise and diet we need to give them. And also finally, as doctors, we should understand whether he fits into treatment of insulin or whether medications are enough and so on. So lifestyle changes can definitely delay the progression of diabetes and its complications. Lifestyle changes include diet, moderate intensity, physical activity. Once again, this is for different age group. Elderlies may require a different approach totally. So brisk walking of around 2.5 hours each week is recommended. Approximately 20 minutes of intensity work every day or 30 minutes every day, 20 minutes every day or 30 minutes if they want to take break on Saturdays and Sundays. So in general, we can tell half an hour of a good intensity of exercise based on their interest we can do. It can be walking, it can be yoga, aerobics, also based on their physical capacity. Simplest for our people is brisk walking of around half an hour is suitable for most of the people. And also this is the first line of therapy. Once again, I want to emphasize that all the doctors and all of us, we should emphasize this to all our patients. So diet, adequate attention should be given. So weight loss should be promoted. We should encourage the patients to lose weight. As I told that obesity will improve insulin sensitivity. So to go to the books, carbohydrates around 50 to 60% should be the account for the total diet. It should be more of high fiber because fibers will decrease the absorption of glucose. Fats should be around 25 to 35 and protein should be around 10 to 15%. Usually proteins can be from both animal and vegetable sources. Excessive salt should be avoided. So we should encourage patients to take more of fruits, more of vegetables, more of complex carbohydrates, avoiding refined carbohydrates like maida, polished rice. We can ask them to take more of unpolished rice, millets, and whole grains, and so on. Physical activity promotes weight reduction and improves sensitivity, as I mentioned. and regular exercise should be tailored to the individual patient fitness. Fruits should be encouraged rather than fruit juices. Many patients inquire about fruit juices, but juices will lose its fiber content once it is made into juice. So whole fruits should be used. Brown fats, cholesterols should be optimized. As advised to reduce the amount of fat intake. Advice used to take more of PUFA fats. Free foods less than 20 kilocalories per serving. Skimmed buttermilk, these can be used. Salads, we can encourage patients to take more and more of salads in each food and reduce the amount of carbohydrate in their diet. Fruits, many people ask whether fruits safe in diabetes. Fruits like papaya, apple, watermelon, guava, orange are safe. In general, the glycemic index should be considered with low glycemic index like whole wheat, ragi, brown rice should be promoted. So a patient should be counseled to look into the glycemic index of the food, especially the educated people. Or in general, we should encourage them to take more of whole wheat, brown rice, and whole fruits and salads, and more of fiber diet food. So one thing is no fasting, no feasting should be encouraged. Exercise should be encouraged, and frequent and timely monitoring of exercise have to be emphasized. Now coming to the oral anti-diabetic drugs, there are a whole lot of array of drugs which are available. For practice, in the general practice, I'm going to give some hints or some advantages and disadvantages of each group of drugs so that we can make a good decision. So first and the most important drug which we use is metformin. It is effective, well-established molecules with decades of experience, reduced insulin sensitivity. It is weight neutral. It has a lot of additional benefits like pleomorphic effects, anti-inflammatory effects, and anti-neoplastic effects. So this should be the first line of treatment in any patients with diabetes. Sulfonylureas, after metformin, we have a lot of drugs. We have to have a balanced decision, of thoughtful decision of what should be added next. Sulfonylureas are the important group of drugs. We have vast experience. They are affordable, easy titration, and they are quite effective. Albeit they have other side effects like hypoglycemia, weight gain, and some of them have, especially older generation, have cardiovascular issues, safety issues. So basically, these are effective, but there are a lot of new drugs which have come, but we should make a balanced decision, especially if the patient is overweight, obese, risk for hypoglycemia is more, then we should try to avoid sulfonylureas in such patients. DPP-4 inhibitors, they have revolutionized the field of diabetology. Sitagliptin, vildagliptin, teneligliptin, saxagliptin are the important drugs. They are weight neutral. They do not cause hypoglycemia. They are well tolerated. So in general, they are the good drugs. They do not have much side effects. Weight neutral is the biggest advantage, and they do not cause hypoglycemia, especially in elderlies. It is very, very useful. This is something which I want to dwell some point on. SGLT2 inhibitors, they have brought a huge change in the management of diabetes. Dapagliflozin, empagliflozin, canagliflozin, remogliflozin, they bind their SGLT2 inhibitors, so they increase the urinary excretion of glucose, and it decreases hypoglycemia, decreases the sugar levels. By this, they have a lot of advantages, like they can reduce the blood pressure, they can cause weight loss, which is important. There is 43% decreased incidence of cardiovascular events, 30 to 40% decreased incidence of renal complications also. So they are very good drugs, especially patients who have got cardiovascular issues. SGLT2 inhibitors will help them in both cardiac as well as metabolic. They have some few side effects like genitourinary infections, predisposition to develop DKA in case of if they are given in any illness. Some issues like amputations and fractures, the incidence is very, very less and attributed only to one or two of the SGLT2 inhibitors. But as such, we should be very careful, especially using in elderly patients and who are prone to develop urinary tract infections. We have to be very careful. But they have a lot of advantages in like cardiovascular safety and renal safety. Thiazolidinediones, one of the very efficacious drugs. Of late in between, there was some issues like it caused leg edema, water retention, but the incidence of this is less. So it has come back to the market. It is very efficacious, but we have to look for patients if they develop leg edema and water retention and cardiac safety also. GLP-1 agonists, these are the new drugs. In fact, they're one of the most leading drugs in the market now. So only at disadvantages, they are in the form of injections, either weekly injections or daily injections. Drugs like semaglutide have come, which can be taken orally. So my purpose of putting this slide is just to create an awareness about the various newer drugs which are available. These drugs also promote weight loss also. So this is the algorithm which is put forth by latest ADA guidelines. So it is based on various things, like if patients already has cardiac problems, then SGLT metformin is there uniform in all of the patients. Only thing is, if they have more predisposition to cardiovascular events, then SGLT2 inhibitors are preferred. If they are having issues with weight gain, then GLP-1 analogs, SGLT2 inhibitors, DPP4s are better. If cost is a major issue, then sulfonylureas are better. So basically, crux of the issue is metformin is uniform. Second line has to be decided based on the patient profile and their other comorbidities. So we should target the blood sugars of around 70 to 130 in the fasting range and less than 180 in the postprandial range whenever we are targeting the medicines. So coming to the combination of drugs, usually we start with monotherapy. There are a lot of trials like Verify trial which have come now, which show that the combination therapy at initial itself is very important. But once again, we have to decide on the patient profile, patient's comorbidities, whether single agent or dual agent is required. But in most of the cases, if the HbA1c is less than 8, we do start with monotherapy and follow up subsequently. So metformin is the main drug of choice in most of the patients. If monotherapy fails, then as I mentioned in my previous slide, we have to go on for the add-on therapies. Combination therapy is usually required if HbA1c is more than 9, or if patients are not reaching the targets even after 3 months of monotherapy. Once again, all of these things is quite different in different patients based on their profiles, and individualized decisions have to be taken. So as I mentioned, oral diabetic agents are not recommended in pregnancy. Of late, metformin can be used. During preoperative, perioperative infection, stress, end-stage renal disease, OADs are not given except linagliptin, which is safe in renal failure. Usually we start with the low doses of OADs and gradually increase. So now coming to insulin, just brief word regarding types of insulin based on their duration of action. We classify into rapidly acting, short acting, intermediate acting, extended acting insulins. So it all starts with around onset of action within 10 minutes. And then like insulin degludec, which acts, which is the duration of action is almost around 72 hours. So based on the patient profile, we have to choose which insulin is required. Most of the time we end up giving premixed insulin, which is easy to use, which has combination medications of short acting and long acting, and is ideal for home management of patients. But in acute settings, like in perioperative states, infections, we do use short acting insulin so that titration of insulin can be easily understood. So this is a slide regarding the various duration of action. So this is ultra short acting insulin, ultra short acting insulin, basal insulins, and so on. So ideal regimen is basal bolus regimen, which is followed in admitted patients, where we give 3 shots of short acting insulin and a long basal insulin. So insulin therapy, short term, it is used in acute illness, surgery, stress, emergency, pregnancy, breastfeeding, even in DKA, hyperosmolar state, lactic acidosis, and even in severe triglyceridemia. In long term, usually it is given in type 1 diabetes mellitus, and also in patients who are not able to achieve the target sugars with OADs. So insulin regimen, as I mentioned, once daily regimens are there, and most important in most of the patients, twice daily mixtures of short acting and intermediate acting insulin is available. A regimen of multiple injections, which I mentioned as basal bolus regimen, which mostly resembles the physiological insulin, is the most important one, which is used in patients. So now coming to self-care. So this is something which we should educate all our patients. Patients should be educated to practice self-care, monitor their blood glucose, body weight, foot care, personal hygiene, healthy lifestyle, identify target controls, and finally, stop smoking. This is important, which I wanted to put a slide. Foot care should be taught to all the patients. This is 4 simple steps for foot care. Inspect your feet for redness, swelling, cuts, blisters, nail problems daily. Wear clean, dry socks and proper fitting shoes. Avoid barefoot walking, and wash your feet daily and trim your toenails carefully. So these are the important 4 advices which you can give to our patients. So coming to a small slide regarding diabetic reversal program, which is nowadays talk of the town. So a lot of research is going on regarding diabetic reversal. Basically it takes into consideration intense diet and exercise, but the burning issue is the sustainability. Is a diabetic reversal sustainable? How much, at what cost is all we have to understand. Continuing care and follow-up is required, even though if the patient has achieved diabetic reversal, it is not that it is end of the exercise. He has to continue with the same regimen, same diet, same exercise throughout, and once again continue to follow up with the sugars and diabetic regimens also. So this is something which is upbeat in most of the cities. So these were my references. So this was just a brief overall of diabetes. It's a huge vast area of thing. So with this presentation, I've just briefed all the risk factors, diagnosis, complications, modalities of treatment. As sir mentioned, in next coming few months, we can have individualized, in-depth discussion about individual drugs, individual regimens, individual problems also. Thank you everyone for patient hearing. Over to Javed sir for the discussion.
Thank you very much, Dr. Ashwin Kulkarni. You have extensively explained the whole set of diabetes, right from the definition to the management. Congratulations, in a very short time you have covered everything. The main concept is, in the management of diabetes, what is required is the target organ complications. So target complication right from the head to the toe, we have to cover right from the diabetic stroke, retinopathy, cardiomyopathy, management of different endocrine gland, pan-endocrine, and the thyroid, the foot complications leading to lower limb amputation, and all that we have to take care of. And more so after the lifestyle, previously after the lifestyle, and then the start of the metformin, we had glimepiride and other drugs. Nowadays, it is open field rather. After the lifestyle metformin, you can go for either the secretococcus, sulfonylureas, or the DTP4 inhibitors, as SGLT2, or even directly you can start the insulin at the right. The early insulin initiation can prevent the complication of diabetes. In some of my patients who have insulin reservation in their management, I tell them that we don't have even a single tablet on the earth which can reduce the blood sugar level. All the tablets which we have the classification, it has to go to either beta cells or to the alpha cells management. All this since past 60, 70 years, we had medicine, sulfonylurea drugs, which targets only on the beta cells to produce the insulin. Nowadays, we have something called DTP4 inhibitors, which work on the alpha cell to reduce the glucagon activity. The pancreas secretes 3 types of hormones. The alpha cell secretes glucagon, beta cells secrete insulin, and the gamma cell secretes somatostatin, which regulates these 2 hormones. So now we have very good, extensive, good drugs that can control even the glucagon activity also, suppressing the glucagon activity by the alpha cells. Now, more than this, nowadays, the mass of insulin, mass of beta cell have reduced, because from one generation to another generation to another generation to another, the mass of the beta cells, we could see that it has reduced. That's why nowadays type 1 diabetes has become very common. When we were doing postgraduate in 80s, early 80s, we used to run behind the Vani Vilas Hospital to see one case of type 1 diabetic children. Nowadays, in our practice itself, we see a lot of type 1 diabetic children is because the beta cell mass is getting reduced. The moment you see the beta cell mass reduced, you need to have required insulin. Not only that, of course, as Dr. Ashwin rightly said, the SGLT2 inhibitor, which works at the nephron level, the selective SGLT2-1 and SGLT2 inhibitors, which secretes the glucose from the urine. So glucosuria. So that's why nowadays we use. And nowadays, we don't much depend on the HbA1c. More than glycosylated hemoglobin, we target the time in range, because this HbA1c can vary from person to person. In female patient, it may reduce due to hemoglobin less value. It directly depends on the hemoglobin value. Hemoglobinopathies, various other disorders of blood can also show a lower HbA1c value. That's why what is important.
Sir, unmute ಮಾಡ್ರಿ sir.
Sir, please, ಈ ಕೇಳಿಸ್ತಾ ಇದೆಯಾ?
ಹಾ.
ಈ ಕೇಳಿಸ್ತಾ ಇದೆಯಾ? Hello?
Yes, yes sir.
Yes, sir.
ಈ ಕೇಳಿಸ್ತಾ ಇದೆಯಾ?
Yes sir. Yes.
G. So what is today important more than HbA1c is in the management is time in range. What we call it as a 7-point profile test. So 7-point profile test, like, before breakfast, 2 hours after breakfast, before lunch, 2 hours after lunch, before dinner, 2 hours after dinner, and even at midnight, 3 a.m. So these 7-point profile test also should be.
Sir, hello.
Hello. Doctor ಕೇಳ್ತಾ Hello.
Hello sir.
Sir, you are audible.
ಹಾ, ಕೇಳ್ತಾ ಇದೆಯಾ ಈಗ?
ಕೇಳಿಸ್ತಾ ಇದೆ.
ಕೇಳಿಸ್ತಾ ಇದೆಯಾ? ಸೊ ಅವಾಗ್ರಿಂದ ಕೇಳಿಸ್ತಾ ಇರ್ಲಿಲ್ಲ.
ಕೇಳಿಸ್ತಾ ಇತ್ತು sir.
Okay. Regarding
7-point
the
profile
reversal,
test.
nowadays both ADA ವರ್ಗು ಕೇಳ್ರಿ.
Okay,
Then
sir.
now come to the reversal of diabetes. Reversal of diabetes, both ADA, IDF, RSSDI, we don't believe in the reversal. Rather, it is a remission. We can delay the ongoing complication of diabetes rather than reversing the diabetes. Okay, thank you so much, Dr. Kulkarni.
Thank you, sir.
Hello. Hello.
You are audible. You are audible.
Okay. Sir.
Thank you so much, Dr. Ashwin Kulkarni. Once again, congratulations, and thank you so much for IMA Karnataka State Branch to having given me an opportunity to preside over Dr. Ashwin Kulkarni's talk. Thank you.
Thank you, sir. So I thank and congratulate Ashwin for remaining calm, cool, brief, yet knowledgeable talk about never-ending discussion on diabetes, which you have highlighted very nicely. Some of the good things I came to know about is each and every person will be asking diabetes reversal program. So being a woman and a gynecologist, every woman will ask by searching on the Google, like diabetes reversal program. As Javas sir said, like it is nothing, there is no concept like reversal, it is remission, sir. So that was good.
Remission.
And one more thing was like you have highlighted about the all those diet, exercises, insulins, and drugs. Now, one thing I wanted to ask: what about metformin? Andre adu ellu kandila metformin.
Metformin is the golden standard molecule.
Standard.
After lifestyle, only metformin has to be used.
Okay, sir. So then this
Molecule.
hello. Every person will be, so many of them, so when the patient comes to us, they'll come with their HbA1c level only. So my level is 11, 12, 7.5, 6.5. Based upon that, they will treat themselves andanga, like how much we should take and how much we should not take. As sir said, like 7-point profile test, whether we can advise for all the patient about this, or
Yeah, we have
how
to
often we
advise
should.
so that for self-management, 7-point
Yes.
profile test is very important.
How often we should advise them, sir? Like if the family is having diabetes.
Depend on the patient's control. If the patient, to get the very good awareness, it is very important. Give them some homework to do at least alternate days 7-point profile and come.
Okay, like
So
how
it's,
often we should advise,
motivate.
sir?
It is
the
actually
family history ittandre how often we should advise them? They're not diabetic, but their family history is diabetic.
Yeah, more than the family history,
Yes.
we have to see their blood glucose levels and ask them to get motivated for the self-management, especially patient on insulin. ಈ 7-point profile ಹೇಳಲೇಬೇಕಾಗುತ್ತೆ ಅವ್ರನ್ನ ಎಜುಕೇಟ್ ಮಾಡಬೇಕಾಗುತ್ತೆ. And in our practice, especially for our general practitioners and beginners, I tell my patient that to remember 3 Ds in their management of diabetes. D, D, D. The first D in the management of diabetes is daily walking. So we have to encourage exercise, lifestyle modification by number 1, daily doing walking. The second D is the diet. Diet ಅಲ್ಲಿ ಏನೇನ್ ತಿನ್ಬೇಕು ಏನೇನ್ ತಿನ್ಬಾರ್ದು, ಸ್ಪೆಷಲಿ ನಮ್ ಪ್ರೊಫೆಸರ್ ಹೇಳ್ತಾ ಇದ್ರು, ಪ್ರೊಫೆಸರ್ ಬಸವರಾಜೇಂದ್ರ ಲೇಟ್, ದಟ್ ಎಲ್ಲಾ ತಿನ್ನಪ್ಪ, ಬರೀ ತಲೆ ತಿನ್ಬೇಡ, ಟೆನ್ಷನ್ ತಗೊಳಕ್ ಹೋಗ್ಬೇಡ ಡಯಾಬಿಟಿಸ್ ಅಲ್ಲಿ ಅಂತ. ಸೊ ಆಕ್ಚುಲಿ ಇನ್ ದಿ ಡಿ we have 3 important. Second point is the diet. ಡಯಟ್ ಅಲ್ಲಿ ಯಾವ್ದು ತಿನ್ಬಾರ್ದು ಅಂದ್ರೆ, ಮೊದಲು ತಲೆ ತಿನ್ಬಾರ್ದು ಅಂದ್ರೆ ಟೆನ್ಷನ್ ಸ್ಟ್ರೆಸ್ ತಗೊಳಕ್ ಹೋಗ್ಬಾರ್ದು. ಸೆಕೆಂಡ್, ಆಯಿಲ್ ಪದಾರ್ಥಗಳು ಎಲ್ಲ ಕಡಿಮೆ ಮಾಡಬೇಕು. ಥರ್ಡ್ ಇಸ್ ಸಾಲ್ಟ್ ಇಸ್ ದಿ ಕಲ್ಪ್ರಿಟ್. ಸೊ ಸಾಲ್ಟ್ ಪದಾರ್ಥ ಎಲ್ಲ ಪಿಕಲ್ಸ್, ಇಫ್ ಒನ್ಸ್ ಯು ಆರ್ ಡಯಾಗ್ನೋಸ್ ವಿತ್ ಡಯಾಬಿಟಿಸ್, ಅಟ್ಲೀಸ್ಟ್ 10 to 15, 20% ಆಫ್ ಸಾಲ್ಟ್ ಇಂಟೇಕ್ ಕಡಿಮೆ ಮಾಡ್ಕೊಳ್ಬೇಕು. ಆಮೇಲೆ ಫೋರ್ತ್ ಬಂದು ಡೈರೆಕ್ಟ್ ಶುಗರ್ಸ್. That is the direct sugars, so like sweets, so chocolates, so Pepsi, soft drinks, adella kadme ಮಾಡ್ಕೊಳ್ಬೇಕು. The third D and the last D, the first 2 D is nearly 75% management of diabetes. The last D, unavoidably, the last D is the drugs, medicines. So the moment you diagnose a patient, you encourage them for their lifestyle changes rather than selecting the molecules. So I think we have to spend some time. Patient, any diabetic patient, eye to eye ಕೊಟ್ಟು, ಕಣ್ಣಲ್ಲಿ ಕಣ್ಣು ಕೊಟ್ಟು patient ನ ಸ್ವಲ್ಪ ಹೊತ್ತು ಕುಣಿಸ್ಕೊಂಡು, ತಾಳ್ಮೆಯಿಂದ ಸ್ವಲ್ಪ ಒಂದು ಹಿಸ್ಟ್ರಿ ತಗೊಂಡು ನಾವು ಟ್ರೀಟ್ಮೆಂಟ್ ಹಾಕಿದ್ರೆ, ಐ ಥಿಂಕ್ ವಿ ವಿಲ್ ಬಿ ಡೂಯಿಂಗ್ justice to the management of diabetes. Thank you so much.
So one more point was like microalbumin, the end organ damage. It was like good to know about it. So everyone monitors serum creatinine, but you have said like microalbumin.
Urine microalbumin is the key important to know the early, glomerular filtration rate in the gottagi. Early CKDs we can know and modify the food protein intake ella madibittu helಬಹುದು.
Sir, ಈಗ gestational diabetes patient ಬರ್ತಾರ. So after delivery, their sugar level will be normal, and we can advise them to come.
They spend little honeymoon phase, what is called as after delivery. One honeymoon phase may extend from 6 weeks to even 2 years. Later on, they also become type 2 diabetes.
Okay, sir. Okay, thank you, sir.
Thank you.
One more time, andre ಮತ್ತೆ ಯಾವಾಗಾದ್ರೂ we'll come up with the topic, specific topic, like you said. We'll concentrate on any one topic and talk. Any questions from any of the doctors who have joined?
Sir, what about testing insulin resistance in case of pre-diabetes? Dr. Veena Bhatt speaking from Bhadravati.
Yes.
Yeah, Dr. Kulkarni, answer ಮಾಡಿ ಅದು.
Yeah.
Insulin resistant ಬಗ್ಗೆ.
Yeah, actually there are few methods to check the insulin resistance, madam. We have to calculate serum insulin levels, but it is not always required to test it, because we have indirect evidences like abdominal obesity, weight markers will be there. So this indirectly tell that there is some amount of insulin resistance. So
acanthosis nigricans, all that markers.
Yes.
Okay, but nowadays they say, and there are some labs testing.
Yeah, there are formula, as I mentioned. If it's serum insulin levels, you can measure insulin resistance, but it is not always required in all settings, because if the person has obesity, he has abdominal obesity and diabetes, it almost means that he has high amount of insulin. He will be having resistance. But if you want to have a value, a number to that, then we can definitely check for insulin resistance. It's not like compulsory for all patients, is what I want to tell.
Exactly.
Okay, sir. Thank you. Thank you, sir.
One more thing, young girls are coming with PCODs, polycystic ovarian disease. So what are the chances of them becoming diabetes in their later life?
Whatever.
Like what advice we should give for those patients?
PCOD and insulin resistance are very closely related. Most of the time, they already have pre-diabetes or they are a diabetic patient. So in such patients, the metformin is the best option because it can take care of PCOD also to some extent and insulin resistance and diabetes. But they have to be followed up. That's what they are prone to develop diabetes in their life. So proper monitoring every once in 6 months, checking their sugars. And once again, encouraging weight loss will have a multimodal benefits.
70% of PCOD cases, they will have insulin resistance.
Yes, yes.
Even late.
Yes.
Hello, sir. I'm Dr. Asna Beg, sir, from Gulbarga.
Hello, ma'am.
Am I audible, sir?
Yeah, Asna, you are audible.
Yeah. Sir, you have told about these incretin analogs. Nowadays, people are very much interested in weight loss using these incretin analogs rather than treating the diabetes. They are non-diabetic also, but they are interested and they are taking, sir, actually weekly. Is it really directly can be used for weight loss, or it is only when it is in diabetic patient we can use?
Generally, as in when they were diagnosed, they were basically for diabetes and they were also having properties of weight loss. But
Yeah,
often the liraglutide has been told that it can be used for weight loss also. But I feel only if it is under a proper monitoring with doctors or physicians or endocrinologists, it can be given only in special settings, not like any random person we can give liraglutide just for weight loss. It's my perception. But finally, it depends on the patient's profile, obesity, BMI, and so on.
Okay, sir. Thank you, sir. It was excellent talk, sir. Both the doctors have given a brush up for diabetes management. Thank you, sir.
She is a physician. Let me tell you, she is a physician.
Thank you.
And we both are friends,
Gyms,
sir. Sanjay
attached to
and-
gyms. So,
Yeah.
so one question is there: carbohydrate is more dangerous or cholesterol in diet?
Good.
See, it's to be frank, both are equally dangerous. But for me, it looks like cholesterol. Some amount of cholesterol is
More
always
dangerous.
required in the body. So
Yeah.
cholesterol only in excessive amounts is dangerous. But it's definitely you can't tell that one is good or one is not good. So in excessive amounts, both are bad, and we have to take care of both of them. What is my
Thank
The
you.
role of intermittent fasting, can you tell in diabetes?
So, madam, as far as my whatever experience, what I have read, intermittent fasting has done miracles for a lot of people. It has caused significant amount of weight loss. So I feel intermittent fasting, which has led to weight loss, has definitely improved the diabetic outcomes in them. But there are some side effects related to the too much of delay in the time, and in diabetics, it is more sometimes difficult to titrate the doses of medications and insulin. But in general, intermittent fasting is good, is what my assessment goes, but long-term trials and all are required.
Okay, thank you, sir.
One question by Dr. Rajendra sir: candidates for reversal of diabetes. As so many dietitians are.
As Javed sir just mentioned,
There is only remission.
Remission is a most scientific word because diabetic reversal is nothing but it's an intense diet control and exercise regimens. But at that particular time, the sugars will come down, but it is not like once you stop it, it will continue. You have to continue with the same amount of diet, same amount of motivation and exercise. It has caused decrease in the number of pills, number of insulin dose and all, but sustainability is always an issue. So rather than thinking of reversal, we should think of like some amount of the diabetes can be control can be better. So there's nothing like good candidate or so. Every candidate has to put in a lot of effort to bring about that weight loss, which will help them.
Dr. Ashwin,
Yes,
what are the parameters that you look into to start metformin in PCO? Because we find quite often colleagues use metformin, but don't you think we need to check on the parameters to start metformin? What is your...
Yeah, single most important parameter which we check in our patients is renal function tests, because creatinine should be normal before starting metformin. And
No,
also
I'm
in
talking about young PCOs, no? The adolescents come to us with PCO. Then it's quite challenging because somebody would have already started metformin. So how to justify? I mean, for those adolescents.
Usually metformin at younger age is safe. It's not that it's a quite safe drug. As I mentioned, only two things is it can cause lactic acidosis, and in very elderly, we have to be a little more careful. But at younger age group, at the optimal doses, it is safe. But monitoring their creatinine is required, because creatinine clearance has to be considered before starting metformin therapy in them.
No. What is the indication to start metformin? Of course, we have our own strategies to take care of PCOS. But when do you start metformin? According to you, for if you have PCOS with BMI so much, which
After lifestyle.
Yes, after
yeah, in addition to lifestyle.
Yeah.
I would prefer starting on metformin if they definitely have a pre-diabetes in the PCOS. If they come in the pre-diabetes range, I feel it is best, because it will take care of PCOS also and diabetes also. And it can cause some amount of weight loss also. I think pre-diabetes, we should start with PCOS.
Without pre-diabetes, you can still play with the other
Yes, it's what.
lifestyle changes, diet and all that. Okay, thank you.
Thank you for a brief talk, Ashwin, and a in-depth talk. Javas sir and Ashwin, thank you, both of you. Thank you.
Thank you.
Thank you all the members for giving us opportunity to present a talk, and all the seniors who have attended and encouraged us.
Second time you're speaking on IMA platform.
Yes.
First time you spoke, I think, on adult immunization.
And COVID in the COVID initial
During
part.
COVID time, he was there for Bangalore branch. And you are a member of Bangalore branch.
Thank you. Thank you. Madam, Gulbargadavaru Bangalore ಅಲ್ಲಿ ಇದ್ರು.
Or Gulbargadavara?
Yeah. Thank you. Thank you, ma'am. Good night. Good night, everybody.
Thank you. Thank
And
you.
quit the
Good night. Good night.
Thank you, everyone.
Thank you.